What's up, you guys? Welcome back to another internal medicine board review, and let's just get started. So a 58-year-old woman is brought to the emergency department by her husband due to worsening confusion over the past few days. No abnormalities are discovered on urinalysis. Her sodium is 122, potassium's normal, calcium's normal, urine sodium is high, and her urine osmolality is high. So this kind of is fitting like an SIADH picture. Generally, this is the kind of pattern you're going to see. An elevated urine sodium greater than 20, so 300 is really, really high, and then an elevated urine osmolality. So which of the following is the most likely pathophysiologic mechanism underlying this patient's presenting symptoms? Abnormal stimulation of ADH, so that's kind of what I was thinking already. Excessive reabsorption of sodium in the distal tubules. That doesn't really make sense to me. If they're having excessive reabsorption of sodium, wouldn't their sodium be high? Reduced reabsorption of sodium in the distal renal tubules, increased serum cortisol, and inhibition of aldosterone secretion. So in this case, I think we can easily rule this one out. Reduced reabsorption of sodium chloride in the distal renal tubules. That could be, for example, in the setting of being diuresed. You could have this kind of pattern where you're just dumping all your sodium. Especially, if it's distal renal tubules, you'll be thinking about your thiazide diuretics. Increased serum cortisol. So Cushing's syndrome does not lead to hyponatremia. It's actually, adrenal insufficiency that could lead to hyponatremia. And then inhibition of aldosterone secretion. So aldosterone likes to retain sodium and spit out potassium. And so in this case, aldosterone inhibition could be a feasible option if there is something blocking aldosterone release. But the patient's normal potassium kind of argues against a hypoaldosteronism in which you would see high potassium. So she reports nausea, vomiting, and headache. She was recently diagnosed with hypertension and was started on hydrochlorothiazide 1 month ago. So potentially this might be an option now, actually. She has no other medical problems, takes no other medications, and has no other surgeries other than C-sections. Vitals look normal. Skin turgor is normal. She has no edema. And so skin turgor is normal shows that she's not really volume down. I would say, in the setting of starting hydrochlorothiazide a month ago, that definitely could make you think, this is probably related to the thiazide diuretic that she just started. And that could also cause high urine sodium. It would also cause high urine osmolality because basically the body thinks it's volume down. So in this case, I actually do think this is the right answer now. We're not getting any clear triggers for SIADH. And, her exam seems kind of euvolemic. But the recent hydrochlorothiazide and diuretics can also cause this pattern. Like again, normally this pattern is like an SIADH pattern, but if you're on a diuretic, you can definitely have this pattern from diuresis. So I'm going to put that, and we are correct. Inhibition of aldosterone secretion would show hyperkalemia. And also the body is pretty good at maintaining a normal sodium level, even if you have hypoaldosteronism. So that's also why that answer is not correct. A 68-year-old man is seen in the office for leg pain. The pain occurs in both calves only when walking greater than 2 blocks and is relieved by rest. So this sounds like claudication, which we can think about with peripheral arterial disease. That's kind of the thing, we think of the most when you have pain with exercise like this. And ankle brachial index is 0.5 on the right and 0.62 on the left. So remember, you're looking for ankle brachial index of less than 0.9 to be diagnostic of peripheral arterial disease. So which of the following, when added, will reduce the risk of ischemic events? So Virapaxar, I've never heard of that. Pentoxifylline, that's more for alcoholic hepatitis. We use that. Cilostazol, this does help, although I feel like it may just lead to symptomatic benefit. I'm not sure if it actually reduces the risk of ischemic events. In fact, I think one of the earliest things that you're supposed to do is supervised exercise programs, which is supposed to be kind of the most helpful thing at the outset. And then we have 2 anticoagulants here. So yeah, I think the cilostazol, it is a treatment for peripheral arterial disease, but I do feel like it's more of a symptomatic benefit. And then between warfarin and Xarelto, I'm assuming that the benefit of Xarelto is kind of more clear compared to warfarin. And so I'm just going to go with that. He has a history of coronary artery disease and stroke. He's taking aspirin, atorvastatin, and ramipril. I don't think that really changes anything for me. I think still I would probably recommend him to be on a DOAC. So we'll go with a DOAC. So low dose rivaroxaban has been shown to reduce ischemic events in patients with peripheral arterial disease and coronary artery disease. Warfarin has not been shown to significantly reduce ischemic events in patients with PAD and CAD. Cilostazol is a phosphodiesterase inhibitor. It can improve symptoms in intermittent claudication. Vorapaxar is a platelet inhibitor. It has been shown to reduce ischemic limb events, but it's contraindicated in patients with a history of TIA or stroke. And pentoxifylline looks like it can be used for peripheral arterial disease to treat claudication symptoms, but otherwise it's not effective in the treatment of PAD. Next question. A 62-year-old woman is brought to the emergency department by EMT after she was found vomiting blood by her husband. So hematemesis. She is tachycardic. She's oriented to person and time, but not place. On physical exam, there's dried blood on her lips. So honestly, the first, her being confused to me starts to make me think of, does she have like hepatic encephalopathy? Does she have some esophageal varices, some history of cirrhosis or something? There is no trauma visible on her head, and there are no masses in the neck. Breast sounds are clear bilaterally, and heart sounds are normal. The abdomen is soft, non-tender, non-distended. Her extremities exhibit mild peripheral edema. 2 large bore IVs are inserted. And then her sodium is 142, potassium 4.1, creatinine 8.9, hemoglobin is 9.1. Which of the following is the most appropriate next step in evaluation? EGD, tagged red blood cell scan, upper GI barium series, CT angiography, or colonoscopy. So EGD, if we're thinking this is like a variceal bleed, is probably going to be my answer of choice. Tagged red blood cell scan is generally going to be when you can't find a source of bleeding. A lot of times, we're trying to, like, you do an EGD or the patient cannot get an EGD, and then you look for embolization targets with the red blood cell scan. Upper GI barium series is more for obstruction. CT angiography is not ideal for looking for bleeds. It can, but you need to do like a special GI bleed protocol. And typically we do this more for lower GI bleeds as well, but it could be a potential option. And colonoscopy if we're thinking this is lower GI bleed, but she's coming in with hematemesis, so most likely the answer is EGD. So he states when he arrived home from work, he found her in the bathroom with blood in her mouth and in the toilet. She was unable to give any details about what happened. Medical history shows hypertension and left colectomy for recurrent diverticulitis. Okay, so we don't have any clear history of cirrhosis that I was thinking, but I don't think any of these are really first line. She's actively bleeding, she's tachycardic, she's anemic. The first thing we would want to do is an EGD, because not only can it be diagnostic, but can also be therapeutic. So we're going to go with EGD, and you can see most people got that one right. So yeah, CT angiogram is an option for evaluating upper GI bleeding. However, EGD is diagnostic modality because it can locate and treat the source of bleeding. Tagged red blood cell scan is used for occult GI bleed when it's a very slow bleed. And that's pretty much it. Next question. A 68-year-old man presents to the physician's office complaining of sudden onset severe pain in his left knee for the past 2 days. Crystals seen in the fluid under the polarized light microscopy as shown. When you see blue and white, that is suggestive of negative birefringence, which goes with gout. And so you can see he does have an elevated uric acid, which goes with gout. The rest of his labs look fairly unremarkable from what I'm seeing here. So which of the following is the most likely diagnosis? The only thing is gout crystals tend to be more fine, not kind of rhomboid shaped like this. So actually, I am a little bit suspicious. Let's see. Lupus, gout, rheumatoid arthritis, CPPD, and septic arthritis. So CPPD does have kind of rhomboid shaped crystals, but it is positively birefringent, I believe, which means it does not change in color. Maybe I'm remembering this wrong. Let's see if there's anything else in the question stem. He reports feeling slightly fatigued for the past week, denies trauma or history. His father had similar episodes of severe joint pain, has a history of osteoarthritis and hypertension. He's on lisinopril and acetaminophen. Vitals are normal. Knee is swollen, warm, and tender to palpation. Range of motion is limited due to pain. X-ray of the knee reveals calcifications in the cartilage. Okay, this does sound kind of more and more like CPPD. Inflammatory fluid with a white cell count of 3,500. So if we were thinking septic arthritis, typically you see the white count in like the 50,000s. But when you have like a inflammatory white blood cell count that's a little bit lower, then it can be like gout and CPPD. So I think because it's rhomboid shaped And I'm a little bit confused. I thought it was the other way around with the negative. Maybe this is positive birefringence when you see both colors. So I think we can go with CPPD. CPPD is associated with hypercalcemia and like hyperparathyroidism, which I'm not seeing here. But I think the calcifications in the cartilage is kind of suggestive as well. And also the other thing it's associated with is like hemochromatosis. So that's probably why they give you the ferritin. And now it's making me second guess myself a little bit because all the stuff that they gave us that's like associated with CPPD is negative. But I don't know. I think the rhomboid shaped pattern, the calcifications of the cartilage. I'm going with CPPD, but I'm starting to think that it's gout again. I'm unsure, but okay, it looks like it is CPD. So phew, we're lucky on that one. So in pseudogout, calcium pyrophosphate crystals deposit in the joint spaces, typically in patients over 60 years of age. Okay, I actually thought it was younger patients, but it's not. And let's see, you see the short, blunt, rhomboid, and weakly positively birefringent crystals on light microscopy. Normal serum calcium and PTH levels rule out hyperparathyroidism, which can be a metabolic cause of pseudogout. Gout typically presents with the same symptoms, but shows needle-shaped, strongly negatively birefringent crystals under polarized light. So yeah, let me take a look at this because I have some cards on birefringence. Gout is negatively birefringent, which means it's yellow when parallel and blue when perpendicular to polarizing axis. So that's why I got a little confused. So pseudogout is rhomboid shaped again. But yeah, it's interesting. I got kind of thrown off by the fact that there was blue and yellow ones because it's only supposed to be weakly positively birefringent, but interesting to know. And so just look out for those rhomboid crystals when you're thinking about CPPD. Next question, a 63-year-old man is brought by his brother to the urgent care center with a scalp laceration from an accidental fall. Lab studies are shown. Here's the rash. And interesting, so hemoglobin 12.8, white count 8.2, creatinine 0.9, and his AST and ALT are elevated. Which of the following is the most likely cause of this patient's clinical findings? So he's got like petechiae, basically. I saw TTP here, so it's asking us why he has petechiae. And then the other thing I'm noticing is this like 2-to-1 ratio with his AST and ALT. So I'm thinking, can this be a guy with alcohol use disorder who's very malnourished, and maybe scurvy could be an answer. Thiamine deficiency would cause Wernicke's encephalopathy and not purpura. TTP, again, TTP, we would see much lower platelet counts, but they didn't actually give us the platelet counts. It could cause, that classic pentad of fever, neurologic symptoms, microangiopathic hemolytic anemia, so schistocytes, and then AKI, and then thrombocytopenia. So we don't see any of that. His creatinine is normal, so that seems less likely. Cutaneous small vessel vasculitis, if they gave us a clue that this was, he's got like an autoimmune history, and then there's palpable, non-blanching palpable purpura, then you would think of a small vessel vasculitis. And then acute leukemia, we would probably see some more derangements in his CBC count. So I'm thinking that this is probably an alcoholic patient who's poorly malnourished, was drunk, fell over and hit himself. That's why he had the fall. And then he's got scurvy, which is accounting for all these purpura, all these petechiae. So the laceration requires sutures. The patient lives alone and has not eaten well in the past 5 months. Diet is primarily milk, salami, bread, and whiskey. Family history and personal history is unremarkable. Smokes 1 pack daily. Drinks 10 to 12 cans of beer daily. Dermoscopy reveals the presence of broken curly hairs with a corkscrew appearance, which is classic for scurvy. This also can be seen with like copper deficiency, but this curly hairs with corkscrew appearance, you can see that in scurvy a lot. And then he's got gingival hypertrophy with bluish discoloration. Gingival hypertrophy, this is actually something you can see with AML. And so that probably is why they threw the AML here. But I believe it could probably also happen with scurvy and nutritional deficiency as well. He's got bluish discoloration and friability of the mucosa with easy bleeding. And then rest of the exam, he's got the spleen tip is felt on inspiration. So interestingly, gosh, I'm actually not super sure now because they're giving a lot of different options that could potentially go with AML. The fact that he's got gingival hypertrophy, easy bleeding, he's got these new petechiae, he's got palpable spleen. That kind of stuff is making me think of AML, but palpable spleen, he could also have cirrhosis from his 10 to 12 cans of beer daily, leading to portal hypertension and splenomegaly. So I think given his relatively normal hemoglobin and white count, I think we can be pretty confident that it's scurvy rather than AML, but I can see why AML is tempting with all these other findings that could potentially be related to AML. So we will do scurvy, and 72% of people got it. 18% of people picked thiamine deficiency. That's kind of interesting to me. So the patient's poor nutritional intake, chronic heavy alcohol use, and clinical findings support a diagnosis of scurvy. This is vitamin C deficiency. There is loss of periodontal bone and tooth loss. It can cause impaired immune responses, fever, anemia, lethargy, all these other things. And let's see. AML shows anemia, thrombocytopenia, and neutropenia. It can show nodular lesions with a violaceous color. What's it called? Myeloid. There's some kind of AML cutis thing. AML cutis. Leukemia cutis. So that's how AML could present. And so, although we had the splenomegaly and we had the hypertrophy of the gingiva, it looks like that could be associated with vitamin C deficiency as well. Next question. A 58-year-old woman presents to her physician complaining of a slow-growing, painless swelling on the right side of her face for past 7 months. Immediately, I'm thinking about some carotid gland masses that could happen. We'll see. And then CT findings reveal a well-circumscribed homogeneous mass in the region of the right parotid gland without signs of local invasion. Which of the following is the most appropriate next step in the management of this patient's condition? Order a PET scan, initiate empirical antibiotics, obtain a fine needle aspiration biopsy, start a course of NSAIDs, and refer to ENT for superficial parotidectomy. I actually had a medical student give us a quick chalk talk on salivary gland masses or parotid gland masses, and I can't remember the details of it. I'm sure I have a picture of it somewhere, but I'm not actually sure what the correct answer here is going to be. I'm leaning towards getting a biopsy, but let's see if we can get any clues from the rest of the question stem. So the patient has a history of hypertension, well controlled with hydrochlorothiazide. She also has a past medical history of rheumatoid arthritis, for which she has been taking methotrexate. She does not smoke, no fever, weight loss, or night sweats. Mother is a survivor of stage 3 breast cancer. Vitals are normal. There is a firm, non-tender, mobile 3 centimeter mass in the region of the right parotid gland. So she's got a very significant autoimmune history. And so you can get some kind of autoimmune parotitis kind of picture. And so the fact that it's firm and non-tender makes you concerned for a malignancy. But the fact that it's mobile is a little bit more reassuring. Usually cancers are more fixed and non-mobile. So should you order a PET scan as part of a cancer workup? Empiric antibiotics. I don't see any signs or symptoms that she is infected. Fine needle biopsy, non-inflammatory drugs, and ENT. So in this case, because of her significant autoimmune history, there is a high chance that she could also have some kind of Sjogren's-like syndrome going on. And a lot of times they can get like these sialoliths, which are these stones that build up in your salivary gland. And maybe that can cause the swelling of her parotid gland. And so I'm actually tempted to say starting with NSAIDs to see if it treats this first. And then if that doesn't improve afterwards, then probably doing some more workup like a biopsy. So I really am not sure about this one. So we'll just go with this one. But I'm thinking that's probably what they're going for in this case. A patient with a severe autoimmune history, maybe has some Sjogren's syndrome going on, sialoliths, and having some blockage. So if you do some NSAIDs, maybe that will reduce the inflammation. And that is the incorrect answer. So the answer is what my gut was telling me at the very beginning, which is obtaining a fine needle aspiration biopsy, which I'm sure a lot of people probably would have gone for as well. So it's a pleomorphic adenoma, which is the most common salivary gland tumor. And obtaining a fine needle aspiration biopsy is the next appropriate step. Starting a course of NSAIDs might be considered for symptom relief if there was inflammation or pain. However, in the absence of symptoms indicating inflammation or pain, NSAIDs would not address the primary concern, which is to confirm the nature of the parotid mass. All right, I tried looking for the lecture that we got on the parotid gland masses, but I could not find it. But I may have a picture somewhere. I'd have to dig that up. So let's do one last question. A 40-year-old man presents to the emergency department with a 3-week history of intermittent high-grade fevers, severe joint pain, and a transient salmon pink rash that appears with his fevers and disappears when the fevers resolve. So this is adult onset Still's disease. This is a classic description of it. Specifically, when you hear about an evanescent or a transient salmon-colored rash that appears with fevers and disappears when fevers resolve, immediately you should be thinking adult onset Still's disease. So liver enzymes are slightly elevated. Ferritin is elevated to 3,500. Again, very characteristic of adult onset Still's disease. So hyperferritinemia, transient rash, and hyperferritinemia and fevers. Did I already mention that? So those are the 3 criteria: fevers, ferritin, and transient rash. That goes with adult onset Still's disease. He's got a thrombocytosis, likely somewhat reactive, and then a leukocytosis. So what is the most likely pathologic mechanism for this clinical presentation? Cell-mediated immunity leading to granuloma formation, immune complex deposition causing complement activation, dysregulated cytokine production resulting in systemic inflammation. That sounds kind of like the pathophys for adult onset Still's disease to me. Autoantibody against ANCA causing neutrophil activation, and overactivity of the humoral immune response with excessive antibody production. So this is a really difficult second order question, but in general, when you're thinking about states of hyperferritinemia like HLH and I'm actually a little bit, so I was thinking HLH could be this answer here. So actually, I don't know the pathophysiology of adult onset Still's disease. This one, I was thinking of these hyperferritinemia states probably all cause some kind of elevated cytokine reduction, but this one is definitely HLH, this answer here. Cell-mediated immunity causing granuloma, that's like an autoimmune process. I don't think granulomas are not associated with adult onset Still's. Immune complex deposition, I don't really know what this one is referring to. Can be like endocarditis kind of picture. Overactivity of the humoral immune response with excessive antibody production could be that one. And then autoantibody against ANCA. I don't think it's ANCA. It's not associated with ANCA. So he reports experiencing sore throat and unexplained weight loss. Medical history is unremarkable. And then mild hepatosplenomegaly. So I'm not sure if the pathophysiology of adult onset Still's is the same as HLH. Maybe it's very similar kind of picture, in which case this would be the answer: dysregulated production, but overactivity of the humoral immune response. Adult onset Still's. All I know is it is a autoimmune condition. So I am actually thinking, because it is an autoimmune condition, maybe it's this one where there's excessive antibodies. I totally would have gone with C, but I think this is just like HLH. And maybe the pathophys is slightly different than HLH. So I will go with this one. And shoot, it was the dysregulated cytokine reduction. So let's see. Adult onset Still's disease, it's the same pathophysiology of HLH. So immune complex deposition causing complement activation is lupus. Overactivity of the humoral immune response is also lupus or rheumatoid arthritis. Cell-mediated immunity with granulomas is sarcoid or TB. And then autoantibody is GPA or microscopic polyangiitis. So let's do one more question, because we can't end on a wrong question or a wrong answer. So a 73-year-old man is brought to the emergency department for generalized weakness and dehydration. This is the second admission within a month for hypotension and dehydration. He has 2 additional admissions in the past 4 months related to falls, resulting in fractured ribs and a broken wrist. He states he is sorry he became dehydrated, but he keeps taking his blood pressure pills, even though he was not eating well, to a stomach virus. He lives alone and has no local family. So he's mildly hypernatremic. He's hypokalemic. He's got an AKI, and his creatinine kinase is within normal limits. And then he's got an AKI. This could just be from like severe dehydration. Which of the following is the most appropriate first step in management? Order an EGD, order a swallow study, recommend temporary guardianship, order an EEG, or contact adult protective services. So let's see. A neighbor had not seen him for several days and called emergency services. He was found lying in bed. There were unformed stool. His blood pressure was low. IV fluids were started. History is positive for hypertension and GERD. He's on hydrochlorothiazide, lisinopril, and pantoprazole. He's a thin man with tenting of the skin, multiple contusions on his legs and chest. He's got sinus tachycardia, generalized weakness, and no abnormalities. He lives alone and has no local family. So this guy is clearly unable to care for himself. It does look like these probably are related to just dehydration from continue taking his blood pressure medications. He's got an AKI also, AKI. I don't think EEG is indicated. Adult Protective Services probably is the correct answer because we need to assess his home safety at home. When you have concern for neglect for elders, this is when you think of Adult Protective Services. But in this case, he's living alone. Even still, you would contact them because they would go and do the home safety evaluation. I don't think there's any signs that this patient has dysphagia leading to his poor oral intake, and no need to get an EGD. Temporary guardianship is like conservatorship if somebody doesn't have medical capacity. But in this case, we don't have any signs of that. So it just seems like he's unable to care for himself at home. And so we're going to contact Adult Protective Services. All right, I hope you guys enjoyed this board review and hopefully learned something as well. Please let me know in the comments down below if you have any questions. Thanks again for watching, and I'll see you in the next one. Peace.